Good afternoon, Faith family, and to our community members here. We're so excited to bring another health initiative talking conversation with you. Today we have Dr. Todd Miller, who is a part of the Stanford Health. He is the Director of Neuro Interventional Radiology and Assistant Professor of neurological surgery at Columbia University. Dr. Miller, we're so glad to have you here on today. Before we get started, is there anything you'd like to tell us about yourself?
I have been in town for about 7 years now, and I love working in Stanford. I love meeting the people in Stanford, and it's my great pleasure and honor to be here serving your congregation. Glad to be a part of this evening.
Well, thank you so much. Listen, for those of you who will be coming on, listen, we welcome all of your questions as we go through this presentation on tonight. Please feel free to write in the comment section, and we will definitely answer those questions on tonight. And so without further ado, so we won't belabor the point, we're going to turn it over to Dr. Miller so he can start with his presentation on stroke care.
Thank
Dr.
you.
Miller?
Thank you. So I'm wondering if you can allow my shared screen. Thank you. That's what I'm looking for. Okay. Can everybody see those flowers? I would like to try and make this an interactive session to some degree. So I would like to see if everybody can see this slide on screen. See, answer this test question. So if you look at the top, there's 3 ways to get involved. You can try the web or send a text or scan the QR code, and you should be able to answer questions, and they should show up as we're here together.
So, Dr. Miller, I am trying to scan the QR code from my computer, and it's not picking it up.
That's unfortunate.
For some reason.
I'll try to. Let's see.
Let me see if I can try and make my screen bigger. Technology is great when it works.
Well, I was able to tell you that I like all of the above. That's my answer right there. So I'm having success. I hope you all can too. And it's not going to make or break it, but it's always nice if everybody has an opportunity to participate. So I don't want to waste all our time on this right now. We'll come back to additional opportunities. So the main topic for tonight is stroke. We're going to be speaking a bit about that together. And if we have time, I'll move on to some other information about minimally invasive back pain treatments. And then I'd really like to open the floor to questions. If people have questions, I know radiology can be difficult to understand. I'm trained as a radiologist, and a radiologist is somebody who looks at pictures of patients. So if you've had an x-ray, if you broke your arm or your leg or needed your chest looked at, that's what radiologists do. Your doctor orders a test, we look at the images, and we provide the best answer we can based on what we see. I've got additional training as a neuroradiologist, so I spend my time looking at brains and spines. And then I have additional training after that, performing minimally invasive procedures on brains and spines. So some of you out there, we may have met before if you had a stroke, unfortunately, but if I was able to help you. And sometimes, a lot of patients in town over the past several years I've been able to help with back pain related issues. So there may be people that we know each other out there. It's hard to know who's online at the moment, but I'll say hello if people we've met before. So to focus on stroke, there are three main kinds of stroke. The most common is if a blood vessel to the brain gets blocked, and that's called an ischemic stroke. And when that blood vessel to an area of the brain gets blocked, if we don't open it up quickly, that area of the brain will irreversibly die, and it happens really fast. Another kind of stroke that can happen is you can get bleeding into the brain itself, and that's called an intracerebral hemorrhage. Depending on how large it is and how much pressure it puts on the brain, occasionally the surgeons on the team can go in and relieve some of that pressure. And the final, least common type of stroke that we're not going to really touch on tonight is called a subarachnoid hemorrhage, and that's where bleeding happens around the brain. But if people have specific questions about that, I can cover that in a little more detail. So again, the most common by far is the ischemic stroke, and that's what I am going to focus on tonight. And I was hoping that we could get a poll about what people know about the risk factors of stroke. So if anybody can manage to log in and either text your text message to me, Todd Miller 123, and send the number 37607, or go online to pollev.com, Todd Miller 123. Does anybody know any stroke risk factors?
So let me just say, high blood pressure.
Definitely.
For those of you who are online, if you could just write it in the as well. If you're not able to get to the link, you can always put it into the chat. One came up, diabetes.
Definitely. Well, I'm sorry that the interaction is limited, but I'll move on and I will share the major risk factors. High blood pressure, this is controllable, right? So there are some risk factors that we can help with and some that we have to work around. High blood pressure, we can help with. Diabetes, we can help with. Heart disease, we can help with. Smoking, we can help with. High cholesterol, for sure, we can help with. Male age, male gender, older age, and certain ethnic backgrounds are at higher risk, and of course we need to work around those. But to focus on the correctable ones, the most important thing is to get regular physical evaluations by your healthcare provider and make sure that these controllable problems are under the best control possible. And we can talk more about that if we have more time. I don't like to yell at people and tell them, hey, get your blood pressure under control. Hey, stop smoking. Hey, eat better. I think anybody who comes to a doctor will hear recommendations like that. I think the hard part is changing our behavior. I think everybody as a human being experiences those types of problems of they know what they should do, they know what they shouldn't do. It's just actually doing those things that can create the challenges. And we could talk about that. But to get back to the topic of ischemic stroke, so that area of the brain that's not getting the blood supply that it needs, it dies very quickly, and you lose millions of neurons very quickly. Those are the cells that make up the brain. And the way those cells talk to each other is through these things called synapses. And the cables that talk to each other are the myelinated fibers. And this is happening every minute. You're losing billions of synapses, lots of cables, and those can never be replaced. So the goal is to, if someone is having symptoms of a stroke, and we're going to talk about this, to get care as quickly as possible. Unfortunately, from time to time, I encounter patients who aren't feeling well, who aren't feeling right. And for everyone's got their reasons, of course, they don't want to come in, and they'll try and go to bed and rest. And when they wake up in the morning, things haven't gotten better. And unfortunately, by that point, it's irreversible. So we're going to talk a little bit about what are the things you need to look out for. But I'll talk a little more about how common these problems are and what the numbers are. These are annual numbers of patients in the United States who have death or major disability as a result of heart disease, cancer, accidents, and strokes. So it's over 160,000 patients a year in the United States have a stroke. And what I see time and again, when I speak with families, they're always very upset, of course, and they regularly tell me their loved one was fine yesterday. And they're just so surprised and dumbfounded by how awful things have gone so very quickly. It's without warning, it's a nasty surprise, and it's usually very disabling. And the goal really is to prevent it from happening to begin with. So going back to those modifiable risk factors, working on those is critical. Getting regular checkups is critical. And then the other is if someone is experiencing the warning signs of a stroke, what are we looking for to take things seriously? What signs and symptoms are there that you need to look out for? And if you see them, you have to come to the hospital or bring your loved one to the hospital as quickly as possible. Don't pass go, don't take a nap, don't have a cup of soup, don't go for a walk. Come right on in so we can evaluate you and prevent that nasty surprise.
Let me ask you, Dr. Miller, real quick. One of the things that you put on the screen in terms of things that could affect the stroke was gender and ethnicity. Male gender, so being male, you're more likely to have a stroke. But then ethnicity, what ethnicity or race are more prone to strokes?
So folks of African American background are more likely to have a stroke than Caucasian folks. Folks who are Asian Pacific Islanders are more likely to have a certain nasty kind of stroke. There's a type of atherosclerosis or hardening of the arteries that can occur in the heart and cause heart attacks, but it can also happen in the brain. And folks from the Pacific Rim and some areas of Africa are at higher risks of those types of problems. But generally, it's African American folks are a little more at risk than the general population in the United States. So again, not that we can fix that, we work around that, and we work very intensely on the controllable risk factors in that demographic to really try and help people have the least risk that they can tolerate in their life. And there's a lot we can do. We can help everybody. And that's my goal, is to make sure everybody's aware that we're there for you to help you not wind up on my table and not wind up disabled or even worse from a preventable problem.
Now, you talked about some of the risk factors: hypertension, diabetes, heart disease, high cholesterol. And so I think we've heard it probably from every healthcare professional. Exercise can help prevent a lot of this, along with change of diets as well. And so what would you add anything else to what we've always heard in terms of that?
You know, that is a big topic, and I'm happy to discuss it. If you think that's of interest to everyone, I think the real challenge is behavior change.
Mm.
I think, like you said, you're well aware. Anyone who's ever seen a healthcare provider is well aware of what they should be doing and what they should not be doing. I think it's easy to say, and everyone's has challenges in their life. There are stressors, we're busy, sometimes we're barely making it from one day to the next, taking care of everybody and everything we have to do. And to layer on top of that, making changes to our lifestyle can be too much. And one of the challenges is the injury to our bodies from not correcting these correctable things accumulates slowly over time. So from one day to the next, you don't notice. But days pass, and weeks pass, and months pass, and years pass, and those negative impacts on the body start to become more apparent. So if I could kind of wave a wand and solve people's problems, I would say helping people change their behavior to the extent they want to. I'm not going to push people beyond what they want to do. If people are interested, there are things that can be done to make changes stick. And that's the hard part. That is the hardest part of what we do trying to prevent this. Raising awareness and helping people make those changes. Because it's not complicated, but it's not easy.
Excellent. Thank you.
And I'm happy to talk about that further if people have questions, but I would definitely like to focus on this information here. I talked about before that there are things that you can experience as a patient, symptoms that are extremely important to pay attention to. And if you're having these types of problems, the only thing to do is get to the hospital so we can evaluate you, understand why it's happening, and fix it if at all possible. And the acronym is BFAST. The B stands for balance. If suddenly you're unable to maintain your upright posture without wobbling around and you don't have another explanation for it, that's one thing. Another is if you have inability to see suddenly or double vision suddenly, that's an important marker. And then several people out there may have experience with loved ones who have asymmetry of the face, where there's a facial droop, where the eye doesn't open properly and this fold flattens out and the corner of the mouth drops down. That's a very important clue. And on the same side of the body, there might be weakness of someone's arm. They can't lift their arm or they can't hold on normally. That's a very important one. And then speech. And sometimes speech means someone suddenly can't speak at all. Sometimes someone's speaking in a way that their speech sounds garbled or slurred. And sometimes they're speaking words that are nonsensible words. If any of those things occurs, the last letter is T for time, to get to attention as quickly as possible, because any of those things can be a marker of an ischemic stroke happening. And the faster we restore blood supply, the better chance someone has of returning back to themselves or limiting the damage caused by that blocked blood vessel. And that's the whole thing. The less damage you get, the more likely you are to recover and survive. So BFAST is very important. And here's a little cartoon of that blood clot again. And the first thing we do for everyone that we discover or we suspect is having a blood clot is we give intravenous medicine that can dissolve that blood clot. And the faster we do it, the better. The faster we do it, the better blood supply is restored and the less stroke damage occurs to the brain. And some people get better right away and they don't have any more symptoms. Sometimes that blood clot won't go away, and I'll talk about that in a minute. What do we have here? Okay, so this is a view of the undersurface of the brain. These vessels are the carotid vessels that are cut because to take the brain out in this cartoon, you can feel your carotid in your neck by feeling your pulse, and this is how it continues up into the brain. And once it gets into the brain, it divides. It divides into this middle cerebral artery, MCA, or this anterior cerebral artery, or ACA. And in the back of the brain, this is the brain stem, there's a major vessel called the basilar artery that keeps the brain stem alive. So if one of these is blocked, the symptoms are usually quite severe. It's not something that people would go unnoticed. And patients come to us with these blockages, and the intravenous medicine tends not to work. So we have to do something more than that. This is a series of images from a brain vessel catheterization. Many people may have heard of heart catheterizations. If you've ever seen an X-ray before, a chest X-ray or something like that, all you normally see on an X-ray is the bones. You don't see the blood vessels. The way we allow the vessels of the brain to be seen is to place a plastic tube either through the wrist or in the groin, and we snake it all the way up to that vessel in the neck, the carotid artery, and we inject contrast medicine. And that contrast shows up as black on an X-ray. And you can see the little ghosts of the bones of the skull and the face, but what you really see is the artery filling in. And what we're doing here is we're injecting, and we're taking a series of images every second. And that is showing us the blood flow to this half of the brain. And what you'll notice is, just like the branches of a tree, you have your trunk, and then the branches divide into the main large branches, and then there's tiny twigs that show up as time passes, and then the brain itself, the substance of the brain, fills in. There's these tiny vessels called capillaries between the arteries and the veins, and that's what's filling in. And then the capillaries fill, and they fill some more, and then the blood drains from the brain through the veins. I have to practice that. The veins fill in, and this is where the jugular vein drains the blood from the brain. So this is a brain angiogram, a catheterization of the brain. And we do this when we think we have to go inside these vessels and take out those blood clots.
Let me ask you this, Dr. Miller. There was a question, do the 3 types of strokes all follow BFAST signs? And are there other signs we should look for?
That is an excellent question. So yes, they generally do. Some of the larger strokes may result in a loss of consciousness, and those typically are not ignored. People coming to us, they don't wait on that. Sometimes people will pass out, or they'll vomit, or they'll suddenly have a severe headache. The bleeding types of stroke, the bleeding into the brain or the bleeding around the brain, those are typically accompanied by a severe headache. Whereas these ischemic strokes, the blood blockage strokes, frequently are painless. It's just a change in someone's neurologic function.
Excellent. Excellent. So with the bleeding, which is, I believe, the hemorrhaging stroke, let me ask you about this. One of the things you said with the is that in order to get for the blood clots, medicine is given to dissolve the blood clots. Now, does that medicine ever, and then when people have strokes, they're given medicine to thin out the blood or whatever. Does that ever help to contribute to like a hemorrhaging stroke or any? What are the side effects? Let me ask.
That's an excellent question. There's no free lunch, right? So if you're giving a powerful clot dissolving medicine, one of the nasty side effects that we hope to avoid is bleeding. You can get bleeding into the stroke area of the brain. There's always going to be a small area of stroke, even if we open that vessel, and that area is prone to bleeding at a rate of around 7%. There can be bleeding from the gastrointestinal tract, so people can get bleeding if they have an ulcer history. They can get bleeding into the intestines. If they've had recent surgery, that can be a reason not to give these medicines that can create bleeding. And if you've ever had a history of bleeding in the brain, we pause and we determine the severity of the stroke because we don't want to reactivate that brain bleeding. And in those patients, we may skip the clot dissolving step and go right into the vessel and try and open it up.
Excellent. So let me ask you this. For those who have experienced bleeding in the gastrointestinal, so what steps should they take at this point there?
So when we're fortunate, patients are able to communicate with us, even if they're having a stroke. Or if they can't, their loved ones are by their side and able to give information. And sometimes they've been to the hospital before and we have records. And what we try and understand, number one, is something called the last known well time. So the last time the patient was seen at their normal self without any of the reasons they're being brought to the hospital. That's important because we can't give the intravenous medicine beyond 4.5 hours because that risk of bleeding goes up. If the family is there or the patient can share with us themselves, or we have records of someone who's had a history of bleeding, whether it was gastrointestinal or recent surgery or in the brain, we have to balance the severity of their stroke with the risk of bleeding from the clot dissolving medicine. And we gather as a team and chat with the family, try and figure it out. Certain bleeding scenarios you can correct. If someone's losing blood from the gastrointestinal tract, but you spare them a major disabling stroke, you can replace blood in most patients if they don't have an opposition to it. And you can spare their brain by correcting the stroke. So sometimes we'll take these risks if someone's stroke symptoms are very severe. Other times we skip the clot dissolving medicine and go right to the intra-arterial stroke intervention that I'm going to show you. Did that answer your question?
Yeah, yes, sir.
Okay. So I was showing you the brain catheterization. This is a cartoon showing that carotid artery in the neck, and it's showing that middle cerebral artery with a blood clot. And this is what it would look like from the brain catheterization. And we put tools up there to open things up again so it looks normal. And I'll show you what types of tools we use. We actually go from the groin and sometimes through the wrist, and we snake a small plastic tube called a catheter past the heart, past the neck, all the way up into the brain. The patient is awake if possible. We give them intravenous sedation to keep them comfortable. If they're uncooperative, which sometimes happens, or for some reason they're having trouble breathing on their own, we will put patients to sleep with a breathing tube. We put these catheters, which are actually vacuum catheters. They're connected to a vacuum pump, and we try and just suck the clot out with these tubes. And if that doesn't work, we can deploy devices. These are older generation devices, this coil retriever and this aspiration device. The newest generation is something called a stent retriever. People may have heard of cardiac stents that patients have, where you put a expanding wire mesh into a narrowed vessel to open it up. And those are normally left behind in the heart. For the brain, if there's a blood clot that we need to remove with these stent devices, it's firmly attached to a wire. So we deliver it through these catheters all the way up into the affected vessel, and then come behind it with the vacuum catheter, hook that catheter up to a vacuum pump, and then use this wire that's sticking out of the access site and pull everything out together to try and remove the blood clot. And I can show you an example of that in a moment. And the reason we do this is a very important principle that I want to take a moment to explain. I told you before that the blood supply, the arterial tree to the brain, it looks very much like a tree, where you have the trunk and then major branches and then progressively smaller branches. And the way the vessels of the brain work is if you have a major branch blocked and your anatomy allows for this, you can get blood coming around the corner another way to feed the area of the brain that would normally be without blood supply. And the reason patients will come to attention, even though there are helping vessels, is this area of brain that's pink, labeled penumbra, is not getting enough blood to function normally. But it is getting enough blood to keep those nerve cells alive. The area just next to the clot is not getting enough blood to stay alive. But if these helping vessels weren't there, this whole thing would be gone immediately. So if you're fortunate and you get one of these big branches blocked and your anatomy allows for helping vessels, kind of like if there's traffic on 95 and you get off to take the Merit, you can still get where you're going. That's what happens to the blood supply in the brain. It bypasses that accident and gets to the area of the brain it needs to go. And when you come to the hospital, we take lots of pictures of your brain, and it's thousands of images. And we use artificial intelligence to help us quickly interpret these images. So you come to the emergency room, we take scans of your brain, those images are sent to the cloud, and artificial intelligence computers help us identify people with that penumbra, which is the area that's not getting enough blood to work normally, but is getting enough blood to stay alive. And if we identify a patient with a penumbra that we can save, we bring them to a procedure where we open the vessel with the tools that I showed you before. And here is an example of 3 different patterns that we can see when patients have a major vessel blockage. So this is a CT scan of the head, a single slice, and patients get an intravenous injection of contrast medicine, just like from the angiogram pictures I showed you. So you can see the vessels in an angiogram. You can see the vessels in a CT scan. Normally, there are no vessels to be seen. When we inject contrast, you can see the vessels. So we inject contrast, and if you compare in block number 1, the image inside the circle, if you look at the amount of vessels you can see and compare it to the other side, it's about the same. If you look at block number 2, these are all 3 different patients with the same problem, a major branch occlusion, a blockage on this side of the head. If you compare the white vessels that you see here inside the yellow circle with the other side, can you agree that there's less white vessels over here inside the circle than there are on the other side? But there's still some. Compare that to the 3rd pattern, where it's empty compared to the other side. So what the computer tells us quickly with thousands of images, it will tell us which area has already had a stroke, which is in red, and how much penumbra there is, amount of brain that if we don't open that vessel, the patient stands to lose. And in pattern number 1, there's a match. A small stroke has already occurred, and there's not a lot of brain left to be fixed by doing a procedure. We don't do anything for a patient like this. Pattern number 3, the whole hemisphere, half of the brain, has already had its stroke, and there's nothing to save. That's not a patient we would usually help, because opening the vessel will not improve the outcome. The patients that we hope to find, if they make it to us in time, they're always going to have a small stroke, but there's this large area of brain to be saved. If we open the vessel, the green area will not have a stroke, so we save a large stroke from happening. If we don't open the vessel. This whole area will look like this, a big stroke. So those are the patients we're looking for. Those are the patients we can help.
Let me ask this. Here's another question from online. How long should it take to get these images and any intervention to preserve brain function?
The simple answer is as quickly as possible. So if someone comes in with a suspected stroke and we recognize it in the emergency department, people start running. People start acting really quickly. We try and get someone scanned as quickly as possible. Ideally, when someone comes to the door of the emergency department and they have a branch blocked in this way, we try and get it open within 90 minutes. That's aspirational. We try and do that. It doesn't always work that way, but that's what we aim for. And the faster, the better. So I want to show you an example of an angiogram of somebody who has a major blockage. So this whole area over here is not filling in with blood. So that's one of a patient with a blocked vessel. And then there's a wire and a catheter going past the blockage, and you can see the patient's awake. They're breathing and they're moving. And we're putting that stent retriever device, and here's the end of the catheter. All you see is the little ring coming, and I'm going to pull it out, and the patient moves because they feel it. I'll show it again, hopefully, yeah. Here's the stent device and the vacuum tube device, and we pull it out, and the patient will move. And then we have this. So we remove this clot from this area, and then we take additional pictures and show that the area has filled in with normal blood supply. I remember this patient very well. He was on the table, and he was unable to move half of his body, and he was unable to speak in a way that we could understand. And the moment we pulled this out, he started moving. So this radiologists look at people in reverse. So this is the right side of the brain. The patient's left side was paralyzed when he came in and he couldn't speak. But when we removed that blood clot, suddenly he began moving his left side, and he began complaining to us about being on our table. He wasn't sure why he was there. So it can be really dramatic. So a change from this to this, and it basically takes someone who is at risk from a fatal stroke, and it allows them to spend a few days in the hospital and then go home instead of having a major disabling stroke or even die from a stroke. I hope those videos played for everybody.
Yes, I was able to see it on my end, so I'm sure everyone. Let me ask you this. So you said there were some things we were able to do in terms of lifestyle change. So the hope is, and in the comments they did say they were able to see the video. So the hope is that people would want to change their lifestyles to have a better quality of life. And you said, there were some things that you could talk about. I know we're quickly running out of time, but can you just touch on that?
I think the easy way to approach this is to speak about those folks who want to make a change. I think that's a whole other ballgame when you've got folks who are resistant to making a change, and that's another conversation. But if someone is interested, I would say the first step is to see your healthcare provider and identify where you are on the health spectrum. Are you a healthy person, or do you have a lot of known health issues? And I think we deal with people like that differently because, you can be a little more gentle with someone with chronic health issues, and it's never too late to make a change. Don't ever think that it's too late to make a change and that my time is up and my die is cast and be fatalistic about it. We can always do something to help. And you may have tried before and failed, but we're here to help. And I think if you have a healthcare provider that doesn't give you the attention and the support you need to make those changes, we're here to help provide you with an alternative, someone that will walk with you and work on your terms to help you make the lifestyle changes you need to make. And again, I don't think they're complicated lifestyle changes. I think most people could tell you what they need to do. It's more a matter of how to do it sustainably. And I think we all have life challenges, and I want to acknowledge that. Not everybody has the time. Some people are under a lot of stress. Some people have financial issues. Making the most of what you can in a stepwise approach, taking one small change and taking small steps in the direction towards better health over time can add up to a major difference in your life. It can spare you from showing up on my table. You don't want to meet me like that. You want to meet me like this. So that's the first piece of advice I would ask is whatever small steps your healthcare provider can suggest for you, and take those baby steps. Ideally, enlisting someone who you care about or who cares about you to walk with you. And the more people you have on your team, the more likely you are to be accountable and stick with the program. If you try and do it on your own, it can be done. But experiments have shown that people who work with a team, loved ones, friends, their congregants, they're more likely to stick with a change.
Excellent. So with that, let me put in a plug for our healthy living, what we've been doing with both our walking in Scalzi Park on Saturdays at 8 a.m. in the morning, and then on Mondays with our line dancing. Just small, as Dr. Miller said, just small changes can make big difference. And so if we can get moving, that's what we've tried to do, Faith, is try and do small things to make a difference. Dr. Miller, I want to thank you so much. As I mentioned to you earlier, you know, one of the things we do know is that that strokes affect the African American community at a higher rate than any other, and so it is something that we really need to pay attention to and really try and address it before we get to a point where we may be seen on your table. And so I just want to thank you again. I want to thank Stanford Health for giving us this platform where we could bring on some of the different doctors to talk about various health issues as well. And this has been a great conversation regarding stroke care. Now, Dr. Miller, quick question. If someone had more questions that they would like to pose with you, is there a way to get in contact with you?
I'm looking. I normally have my email here for you. Let's see. Let's see if I have it here. There we go. Normally, yes. So it's not. It's simple. It's T Miller. I will do this.
And I'll write it right in the.
Now the hospital has email filters.
Okay.
So please don't get angry at me if your email doesn't get through. If you're willing, if your congregants want to send messages to you to pass along to me, if they can't get through, that would work as well.
Okay.
And
Okay.
if you find that you're getting a lot of similar questions and there's something I can come back and explain in more detail, I'm very happy to answer any questions and encourage everybody's walking in a direction towards better health.
Wonderful. Let me ask one last question. I know the time is far spent, but you showed us the three different types of strokes. In terms of the strokes and the mortality rates of those strokes, what would they be?
So the subarachnoid hemorrhage type, the bleeding around the brain, is usually a devastating illness. About half people who suffer from that don't make it to the hospital. They pass before they even get in. And maybe a third of people who make it to the hospital don't survive. So that's a very devastating illness, and fortunately it's not that common. People who have bleeding into the brain usually survive. It depends. Occasionally, especially in much older folks, or if the bleeding is large and they come to us already in bad shape, sometimes we can't save them. But occasionally, especially younger folks, you can have brain surgery to remove the pressure that's caused by a large bleed. You might still have a lot of disabling injury, but we can perhaps save you. And then the ischemic type of stroke, it is highly dependent on the size of the branch that's blocked, how long that blockage has occurred, and unfortunately how old the patient is. And when I say unfortunate, there's nothing you can do about it. So older folks, even if they have a relatively small or minor stroke, that can be enough to really knock them back to a point where their quality of life is minimal. And a younger person can sustain a very large ischemic stroke and undergo rehabilitation and therapy and do quite well over time.
Excellent. Excellent. Well, thank you so much, Dr. Miller. Are there any closing thoughts or comments you'd like to have?
I hope that what I was able to present was understandable. I tried to make it as clear as I can. If people have things that they'd like to bring up that weren't clear, I'd be happy to clarify. And again, I think the name of the game is prevention and recognition. That be fast, balance, eyes, face, arm weakness, speech, and time are critical. Don't rest if you think someone is having a stroke. Bring them in so we can tell you for sure and treat them if possible.
Well, let me say, Dr. Miller, this was phenomenal. And we're getting comments online that says the same thing too. Just before I close, and I had not shared this with you, about a couple of months ago, we had one of our members in our congregation. She had come to church, and many of the members had mentioned that she seemed to be off in terms of her balance and everything. And during the middle of the service, she actually fell. At that point, we called the 911. They came, they took her to the hospital. That was one of and what was relayed back to us was that she had a stroke. And one of the things is, if we had that be fast, maybe if we had that before this time, maybe we could have gotten her attention ahead of time. So I think this is right on time. It is something that we can definitely use and something that is definitely needed. So thank you again.
You're very welcome.
Well, y'all, this ends our live broadcast with Dr. Miller. Again, we want to thank him for his time. If you have any questions, please feel free to email the church office and we will get those to Dr. Miller. All right, listen, y'all have a great day.